Okay, hello everyone. Thank you so much for joining us here today. We're thrilled to have you here for this exciting webinar on PDT user experience and clinical benefits in retinal treatments. My name is Laura Vesala, and I work as an R&D engineer here at Modulight, and I will be your host for today's webinar. I'll be guiding you through the session and ensuring everything runs smoothly. Here's how today's session will go. First, we will show you a quick video about Modulight as a company and what we do here. Then we're honored to have Dr. Ryan Vogel joining us in this webinar, who is a vitreoretinal specialist and founder of Advanced Retina in Wisconsin. In addition to being an experienced retina specialist, having performed thousands of eye surgeries, Dr. Vogel has also served as the primary author in multiple peer-reviewed ophthalmology journals on topics including age-related macular degeneration, central serous chorioretinopathy, and retinopathy of prematurity. Today, he will share his experience in advancing retinal care with PDT and using the ML6710I laser for PDT treatments. Dr. Vogel's presentation is then followed by a Q&A session where you can ask him your questions. And then we have Mr. Robert Perttilä also joining us in this webinar. He is our specialist in the use of PDT for ophthalmic indications, and he will present the latest evidence of PDT for the treatment of neovascular AMD, PCV, and CSR. Mr. Perttilä's presentation is also then followed by a Q&A session where you can ask him your questions. And lastly, at the end, I will give a quick demonstration of the key features of the ML6710I laser that we have on display here. Before we get started, just a quick note on logistics. If you have any questions during the presentation, please feel free to type them in the Q&A box or raise your hand at the end of each presentation if you wish to speak. We'll address as many questions as we can during each Q&A segment. So first, a little bit about Modulight as a company.
We do lasers and optics for personalized medicine and better life.
Modulight is a unique, vertically integrated company. We design and manufacture tailored lasers, which are used in demanding applications, from closely regulated medical treatments and flow cytometry to quantum computing. We start from epitaxial structures and custom mechanics, and go all the way to devices for cancer therapy. Thanks to our in-house design and manufacturing, we can guarantee supply and change control. Cloud-connected devices offer preventive maintenance and predictive analytics. Now let's get started with today's webinar. It's great to have all of you on board.
So that was a short introduction into Modulight as a company and what we do here. Before we move on, once again, I want to thank you all for being here today. And without further ado, let's dive into Dr. Vogel's presentation. Dr. Vogel, the floor is yours.
All right, let me just get my slides up here. All right, well, thank you for the introduction, Laura, and thank you for inviting me to be here. I'm excited to share my thoughts and experience with the Modulight ML6710I PDT laser. I've been using this for a few months now, and I have a few cases here to show. Just a brief disclosure agreement. I'm receiving financial compensation from Modulight, though this does not influence my opinions expressed here. I'd like to first start with an overview of photodynamic therapy, or PDT. What do we use it for, just for people who may not be familiar with this modality? Central serous chorioretinopathy is the most common indication in the modern era. It's also been shown to be very effective for patients with polypoidal choroidal vasculopathy, which is sometimes seen as a variant of age-related macular degeneration. And it differs from traditional AMD in that it responds very well to both PDT and anti-VEGF combination therapy. And occasionally ocular tumors are treated with photodynamic therapy. Choroidal hemangiomas seem to be the most common, but choroidal metastases and others can be treated as well. Finally, we still see photodynamic therapy being used for regular age-related macular degeneration in certain cases where patients are failing anti-VEGF therapy or potentially refusing the therapy. How does PDT work? Well, it requires an intravenous infusion of a photosensitizer called verteporfin, which makes it unique among other laser procedures which don't require this intravenous infusion. A photochemical reaction targets the abnormal blood vessels which leak, and this reduces the leakage, thereby resolving fluid underneath the retina. And the advantage of this is by using a low energy laser, it tends to preserve the surrounding healthy tissue. Whereas with typical photocoagulation, you see laser burns which turn into scars, and those scars can expand over time. With photodynamic therapy, you can avoid that. So why use PDT, or why should you invest money and buy this for your practice? Well, I break it down into three main reasons. First of all, there's an unmet need in the community. Multiple manufacturers have discontinued their PDT laser systems, leaving a gap in treatment options. So it's harder to find these PDT systems. However, and Modulight is the only FDA-approved option currently in production. There is, in my mind, a clinical necessity for this. It remains the standard of care for certain treatments like chronic or recurrent central serous chorioretinopathy. Other treatments are available and have been tried, but PDT seems to be the most effective and the most commonly used. And then it's still a potential sight-saving option for certain refractory cases, such as a patient with age-related macular degeneration who is just not responding optimally to the more common treatments like anti-VEGF therapy. And finally, PDT, having a PDT in your practice can help improve the patient experience. So by being able to offer this treatment in-house, you can save the patient a long commute to another office or to an academic center where sometimes treatment can be more costly. So let me just start with some cases. These are some of the patients that I've treated over the last few months with the Modulight laser. This was a 63-year-old woman. She had a waxing and waning central scotoma in the left eye for 1 year. Visual acuity pretty good still at 20/20, though she was symptomatic. And there are OCT findings and exam findings showed yellow subretinal deposits. Fluorescein angiography showed mild leakage and pooling from the nasal macula. So we treated her, given the chronicity of her symptoms, we treated her with half-dose photodynamic therapy. 6 weeks later, she still had 20/20 vision, but had a complete resolution of symptoms. And we can see on the OCT image that the subretinal fluid has resolved. The fluid did seem to do some degree of damage to the outer retina during the time that it was there, as we can see some ellipsoid zone disruption, but hopefully the fluid won't come back and she'll remain symptom-free. Here's another case. This is a 66-year-old man with blurred vision and wavy vision in the central area. He's had this for 4 months. Visual acuity was 20/50. We see a shallow, irregular pigment epithelial detachment along with a area of subretinal fluid. Of note, this patient did not have any appreciable any drusen that we could detect. So while it looks like age-related macular degeneration at first glance, it probably was not. He did have a thick choroid, and he had a choroidal excavation in the fellow eye. So we believe he had the pachychoroid spectrum disease, basically a spectrum of central serous chorioretinopathy. So here's just another photo showing at a later date the fluid increased. We obtained a fluorescein angiogram. It showed multifocal leakage, somewhat consistent with the choroidal neovascular membrane, but he did not have any response to anti-VEGF therapy. After undergoing treatment with half-dose PDT, we had complete resolution of the scotoma, visual acuity improved, and his symptoms improved. Last case here is a 45-year-old man with a central scotoma, and he complained of basically an upside-down master lock is how he described it. Patients can sometimes have very specific and peculiar descriptions for their scotomas. And he was symptomatic for about 4 months. He had another episode years prior that resolved spontaneously. We did get an autofluorescence image. And one thing to note here is that in that left eye, we do see increased signal or hyperautofluorescence in the fovea, which is suggestive of the accumulation of lipofuscin. So he's probably undergoing some degree of damage to the retinal pigment epithelium due to this long-standing fluid. So given his recurrent symptoms, as well as the chronic nature of the symptoms, we decided to offer treatment. So here's his baseline photo. We did a 4-month follow-up, fluid worsened, and then finally 3 months after PDT, half-dose PDT, the fluid completely resolved. Vision is 20/20, and he is symptom-free. So since May of this year, my practice has treated 16 patients with this device. We continue to treat several per month. In fact, we have 1 today and 3 in total this week that we're scheduled for. So we're definitely getting our use out of this laser that is providing great outcomes for patients. By far, the majority of the patients we're treating are CSR patients, though we occasionally will see other patients like refractory AMD patients that we're treating with this. And so far, everyone's responded very positively. We've had outcomes as expected following PDT, which is a very efficacious treatment, as many of us know. And just the final point is that having a FDA-approved laser by a dedicated manufacturer that comes fully calibrated and warranted, it does instill a certain degree of confidence that we really like. And so it is a important part of our practice because of that. And so with that, I will end the presentation and open it up to any questions that people might have.
Perfect. Thank you so much, Dr. Vogel, for that great presentation. Now we have some time for questions from the webinar participants. So as mentioned, please feel free to type your questions into the Q&A box or raise your hand if you wish to speak.
Hi, Dr. Vogel. Thank you so much for your interesting presentation. I have a couple of questions from people sent to me. Are there any particular subgroups of CSR patients who benefit most from PDT?
I think the patients who benefit from PDT with CSR are basically those who have chronic or recurrent disease and who are symptomatic. Certainly those with subfoveal fluid tend to benefit because the fluid threatens their visual acuity, and patients who have extrafoveal fluid may be best observed. But I'm not familiar with any other specific categories that we can break things down to and say that these patients benefit more. I think patients with CSR just benefit so well from PDT that you can basically treat any symptomatic patient with chronic disease and generally expect them to do well.
Okay, thank you so much. Another question, you said that the patients have generally expressed positive feedback after receiving PDT treatment. But do you have any kind of general feedback from PDT patients?
Sure. Well, I think patients really have a favorable opinion on PDT. We sometimes describe it as a cold laser because of the photochemical effect. It doesn't cause burns in the retina, and that is appealing to them, that you can sort of treat the disease without really leaving a trace. They certainly don't like having, or they prefer it to, having an injection or a needle in the eye. They would much rather take the needle in the arm than the eye. So they do appreciate that. And then finally, the lasting effect, and that generally approximately 90% of the time, patients who are treated with PDT with CSR do not have a recurrence. And so it's kind of one treatment and they're done. Whereas with anti-VEGF therapy, whereas I mean, first of all, it's controversial if it even works for PDT, but theoretically, you would have to keep dosing the patient with that because the drug effect wears off when it leaves the eye over time. So I think patients do appreciate PDT for those three reasons.
Thank you so much. That was really interesting to hear. And, I'll give this over to Laura. So I think we have some raised hands.
Yes, I think we have a question from a webinar patient or webinar participant. So Ulla, could you unmute that participant?
Okay, Dr. Vandenberg.
Yes, hi. I have three questions. One is the Visudyne that you use easily available?
Yes, to answer that, it's easily available. You can get it from many different distributors, McKesson or Amerisource. Yeah, so we don't have any problems obtaining that.
Okay. Are there any negative side effects to the PDT treatment?
One of the big burdens for the patients is that they have to avoid sunlight. FDA recommends 5 days of avoiding sun exposure, so that can be a problem for some patients. And there are concerns about liver disease, since the verteporfin is metabolized hepatically. So we have to be careful about patients with pre-existing liver conditions. We don't see very many side effects beyond that. I have not personally seen any patients who have had a side effect from this treatment.
You mentioned half dose. Is that half the light dose or half the drug dose?
Well, some specialists will use half fluence and some use half dose. I think it's pretty much a toss-up on which one is better. I choose to use half dose. Just reading through the literature, I think there's just slightly more data to support half dose therapy, although I think probably more people use half fluence treatment, meaning half the light dose. But I choose to use half of the verteporfin dose.
The apparatus used to be available from Zeiss and Coherent. Do they no longer sell this apparatus?
No, they no longer sell the apparatus, nor do they service it. So I had a total of 3 Zeiss Visulas 690S PDT units in my practice since we opened, and they've broken down and stopped working, and it was hard to get them serviced, which sort of prompted me to go the Modulight route. So they're out there, but they're sort of in the aftermarket world.
What is roughly the cost of the 6710i?
Yes, we'd be happy to address the questions related to the ML6710i PDT laser towards the end of the webinar, when I'm going to give the kind of the demonstration on the PDT laser, if that's okay.
Okay, then I'm fine for the time being.
Okay, perfect. Thank you.
Thank you.
Any other questions for Dr. Vogel? If there are no more questions, thank you all for the questions. Now we will move on to Mr. Perttilä's presentation. So Mr. Perttilä, the floor is all yours.
Okay, thank you. Let me share my slides. Thank you. Perfect. So my name is Robert Perttilä and I'm working at Modulight. I have specialized in use of photodynamic therapy for retinal conditions, and I will today present you the latest evidence on proper use and also how to find patients for PDT, because basically that is half of the equation of using the PDT for the right patients at the right time. So on this slide, you can see basically the main indications that PDT is useful, and these indications are circled in different sized circles, which indicate what is our estimation of the number of patients in USA in each indication who benefit from PDT. So if I start from the left side, pathological myopia is a condition where anti-VEGF injections are standard of care, but in some selected cases also PDT could be used, for example, for patients that have dome-shaped macula or patients who have had a stroke within the last 90 days. Then presumed ocular histoplasmosis syndrome. It's a small endemic disease, but there is also anti-VEGF injections is standard of care, but also their combination of PDT can be sometimes useful based on the literature. Then we have obviously the largest indication, which is the neovascular AMD. I will go more in depth which specific patient types are there most beneficial to treat with PDT, but you can also find from our webpage our previous webinar where Dr. Mark Nelson, who has treated several tens of thousands of patients during his long career, will explain more of this, of the use of PDT for this indication, and also give some patient examples that he has treated with the ML6710I. Then ocular oncology, we have Dr. Brian Marr, who has also a video on our webpage. You can actually scan this QR code if you want to get more information of these indications and patient characteristics from our webpage. But basically, I can also I will not go into more detail for this ocular oncology in this presentation. For PCV, that is the second largest circle here, we recommend that, or we could say that based on the literature, all patients should be treated with combination of PDT and injections based on the Everest trials. That is the latest evidence, and Everest 2 study, which is the large randomized study, was published just a few years ago. For CSR, I will show an additional slide later on, but basically for chronic disease, as Dr. Vogel mentioned, PDT is a standard of care. Then to the next slide. So here I have highlighted 8 examples where PDT has a place in retinal practice. So first is the wet AMD, where PDT can significantly decrease or reduce the injection burden, since there is a huge number of patients, over 1 million patients in USA suffering from neovascular AMD. Based on both the clinical experience, which I have heard from the doctors in USA, and also the literature, the number of injections can be significantly decreased by having the combination therapy with PDT, and also treatment interval can be extended up to 50%, in some cases up to 100%. Meaning the duration where the patient is free of these injections, which obviously also since they are injected directly into the eye, they also are not as pleasant for the patient as PDT, which is given IV. Also, this of course will reduce clinical workload, clinician workload, so they are not drowned with this huge number of patients. Then secondly, there is economical impact, so it will save costs and support also rising patient numbers. Actually, anti-VEGF injections cost $2.7 billion every year, and it comprises 12% of the Medicare Part B budget. So it's a very significant portion of the whole budget. Then, as a third case, there is a significant number of misdiagnosed cases, so meaning that patient has been diagnosed as AMD patient, but in reality there has not been sufficient imaging done, for example, ICG or fluorescent angiography, which would have shown that the patient actually has PCV or CSR and would respond better to PDT compared to the anti-VEGF for these indications. Then fourthly, there is cases where patients have major neovascularization, and there they might be unresponsive to monotherapy injections, so their combination can improve the outcomes. Then we have chronic wet AMD, so patients who have severe vision loss, 20/200, benefit from full fluence PDT monotherapy, even monotherapy. So typically PDT can be is given as combination therapy with injections, but in these cases where there is a severe vision loss, full fluence PDT can work as a monotherapy, especially those patients that are on anticoagulants. So it basically stabilizes the disease and eliminates the continued need for the injections, even though it doesn't improve the vision itself. Then as a sixth point, we have the PCV patients that I mentioned, so combination therapy for those is definitely has its place. Then CSR patients, so immediate treatment is recommended in cases of autofluorescence discontinuity on the OCT. And then ocular oncology is the last point, where basically, if I say a couple of words, so about half of the patients recover spontaneously, but those who need treatment, PDT is gold standard therapy. And also, in addition to, for choroidal hemangioma patients, PDT is gold standard, but there are also some other rare eye tumors like capillary hemangiomas or retinal vasoproliferative tumors with macular location, as well as some choroidal melanomas and choroidal metastasis who could benefit from PDT. But basically, choroidal hemangioma is the indication, ocular oncology indication where PDT is standard of care. Then, as I already briefly indicated, there is a significant increase in the future for patient numbers, specifically for wet AMD, PCV, and high myopia, and also pathological myopia. So this is mostly driven by aging population, but for wet AMD and PCV, but for myopia and pathological myopia, there is basically even this global pandemic that is also found in younger patients. And because patients get this condition when they are younger, they also will require more likely treatment for that, and it becomes pathological during the patient's lifetime, more likely. So for wet AMD, there is 43% increase expected, and for PCV, 32% increase. So there is definitely also increased need for PDT and reducing the injections for ever increasing number of patients. Then, as I mentioned earlier, I will also tell a few words now about how to spot the right patients and how to basically find out who are the patients who you should give the PDT. So unfortunately, ICGA and fluorescent angiography has lost their place largely in ophthalmic clinics, and OCT imaging has become a standard imaging method as it's non-invasive and very easy and fast to conduct. So it's also ever increasing. There is ever increasing importance to know what signs to look for in OCT, since traditionally PDT patients have been diagnosed using these invasive angiographic methods, but it's a reality that they are no longer that much used in the practice. So with the OCT, there is some signs, especially these peaked retinal pigment epithelium detachment, or PED, that you can see in this picture marked as in arrowheads. And with asterisks, I have marked hyperreflective material within the PED. These are some of the characteristic signs of a patient who has actually PCV, not the standard form of AMD, and should receive the combination of PDT and injections. As I mentioned many times, these PCV patients are not diagnosed correctly and receive only injections, anti-VEGF injection monotherapy, and might not then respond to that as well as they would respond to combination. Because of time constraints, I won't go into detail of what are the specific characteristics in each imaging modality, but they are shown here. Then for non-responding AMD, basically non-responder is determined that there is no benefit in 4 to 6 months after anti-VEGF injections. That could be considered treatment failure, and approximately up to 25% of wet AMD patients experience some non-satisfactory response or some persistent leakage to the retina. And some characteristics associated with poor response to anti-VEGF that clinicians should be looking into are type 1 CNV, meaning the occult form, aneurysmal lesions, patients with foveal scar, high foveal thickness, elevation on OCT, as well as the polymorphism in the AR-MS2 gene. Then about the combination therapy for wet AMD. So it's basically a biologically justifiable. PDT and anti-VEGF injections target different distinct pathways. So basically, anti-VEGF agents target the process of angiogenesis itself, so they inhibit the formation of new vessels, while PDT destroys the existing neovessels and acts as a CNV eraser. If you give only anti-VEGF monotherapy, in some cases, if there is major CNV network already, it might not decrease the existing CNV vessels, although it would improve the visual acuity. So PDT is also very effective in the initial control of CNV, so it quite effectively close the leaking blood vessels in a period of 7 days to 1 month, and then combining the anti-VEGF can also inhibit the further formation of new vessels. Here in the picture on the right, I'm also showing that corticosteroids can be a third component that can be combined, since it then reduces the inflammation inside the cells. Going to the next slide. There is some, okay, great, now it moved. So some of the patients that would benefit specifically for this combination therapy are obviously the anti-VEGF resistant wet AMD patients, then patients who cannot extend or refuse the invasive injections, then anti-VEGF contraindications that are in some patients, such as ocular inflammation, increased ocular pressure, and hypersensitivity to the agent. Then chronic wet AMD patients who have lost most of their macular vision, then patients who show major neovascularization in OCT, patients who have had stroke in the last 90 days, and also patients who just simply want to reduce their treatment interval with this combination therapy. And there is significant clinical experience that a combination actually can lead up to 10 months, in some cases even years of injection-free interval. And also indirectly there can be an increase in efficacy, because as clinicians or retinal specialists know, patients are quite non-compliant with the visits, and also doctors cannot always schedule all the needed injection times basically, or visits that would be needed for the recommended injection intervals. So that's why also by decreasing this interval where there is no leakage, the benefits or efficacy can be also indirectly improved by this combination. Then a couple of words about the PCV. So as I mentioned earlier, Everest 1 and Everest 2 trials have shown that combination is significantly better than anti-VEGF monotherapy alone for these patients. So here on the right side, upper right corner, you can see that the ranibizumab alone leads to about 6 BCVA points improvement over the 2 years period, but when it's combined with PDT, the improvement is about 10 points. And also on the lower figure, you can see that the number of injections with combination therapy, or basically the number of patients or portion of patients that required only 3 to 4 injections, is significantly larger in the combination therapy, while if for the patients who received only monotherapy, the portion is highest when they for the patients who needed 20 to 24 injections. So there is clearly this trend towards lower number of injections for the combination therapy treated patients. Then lastly, for the CSR, couple of words. So CSR, as Dr. Vogel already a little bit explained, the chronic CSR or type 2 CSR is basically a standard indication for PDT, and PDT is a gold standard for these patients. It's approximately 5% of the cases. Then also persistent CSR, so basically meaning that if the resorption doesn't occur within 3 to 6 months, their PDT has its place. And then also I would say that for acute CSR in some selected cases, it can be used. So these cases could be, for example, that autofluorescence imaging shows previous damage, then recurrence in eye that suffered permanent visual impairment from last episode. Bilateral cases can be also treated if there is a risk of complete vision loss. Then reduced visual acuity in fellow eye. So for example, if there is residues of previous CSR episode in the eye that is in the second eye. And then patients who need prompt visual restoration for occupational reasons, for example, pilots, athletes, police or military officers. But this is obviously a bit rarer, more rare indication. And so how you find the patients who respond best to the PDT? They have intense hyperfluorescence, meaning a strong leakage in ICGA. That is all from me. Thank you, everyone, and feel free to have a questions.
Perfect. Thank you, Mr. Perttilä, for that great presentation. Now we have some time for questions from the webinar participants. So as mentioned, please feel free to raise your hand if you wish to speak, or type in your question into the Q&A box. Okay, it seems that everything was clear. So thank you again, Robert, for the great presentation. So both Dr. Vogel and Mr. Perttilä have just given great presentations regarding PDT and ophthalmic indications. So thank you both again for the great presentations. Now I will go through some of the key features of the Modulight ML6710i laser device that we have on display here. So here we have the whole treatment station, which includes the table, the slit lamp, and the laser. So the black cylindrical unit here is the laser unit itself, and it encompasses all the electronics, etc. Attached to the back panel of the black cylindrical unit is the fiber optic cable, which delivers the light to the beam shaping unit that we have right here. The beam shaping unit then generates a round, homogeneous beam that is delivered to the patient's eye via a commercial contact lens. The laser itself is controlled by means of an iPad application available for download in the App Store. The connection between the main unit and the iPad is wireless, realized with Bluetooth technology. The iPad application is connected to our Modulight cloud service, which enables the user to log into the application using their personal login credentials to prevent unauthorized usage of the device. Since the application is connected to our Modulight cloud platform, this enables us to provide the users with training materials as well as other supporting materials. So this includes the support chat that we have right here, as well as the electronic version of the instructions for use manual that we have here as well. And we also have some tutorial videos available here as well. Okay. So once you log into the application, you'll see this planning screen right here where the user can set the specific dose and the irradiance as well as their desired contact lens, which they wish to use for the treatment. The spot size itself is adjusted on the beam shaping unit right here. Once you're satisfied with these specific parameters, you'll simply press Start Treatment, confirm the parameters, and start the treatment by pressing the foot pedal. So that was a quick introduction into our ML6710i PDT laser. To briefly touch on the commercial discussion, the laser is FDA approved for Vesala PDT treatments available on the US market. So we received a question earlier regarding price of the laser. So instead of the traditional CapEx model, meaning purchasing it outright, we are offering the laser with our unique pay-per-treatment model, meaning that you don't buy the equipment, you only pay for using it and doing treatments. This provides a really true cost allocation per patient, which is comparable to that of a pharmaceutical agent. So in other words, when you don't use the device, you don't have any running costs. So just to reiterate, one of the biggest benefits is that there's no upfront investment required, so there's no need to buy the equipment. Right now, as you might have noticed, we're offering webinar participants a 3-month free evaluation period for the laser, and this is only available in the US. For this, we'll send the sign-up form to all interested participants after the webinar. This is a no obligation program. We would just simply come on site to install and train on the laser, and you can use it for free for 3 months. In addition, in case you have any questions on acquiring the laser, please feel free to connect with us by sending an email to sales@modulight.com. We would be happy to discuss the details of the pay-per-treatment model at that time as well. Okay, so thank you all for joining us here today. And before you go, I wanted to share this QR code on the screen, which you can scan to visit our website for more information on the ML6710i PDT laser, as well as view Dr. Nelson's and Dr. Marr's YouTube videos on PDT treatments. Thank you all again.